Good evening, ladies and gentlemen. Good evening, dear students. Welcome to our next edition of case presentations in nephrology. As I was seeing the people who are attending, I could see many new names, many new faculty who are attending. So just for the information of all, I will just share that we started this purely academic initiative by the Indian Society of Nephrology in November last year. And this was targeted for the various PG students and nephro students who are doing residency or fellowship. But as the days passed, several middle seniority nephrologists like me, like Dr. Jasmine and various others, felt that there is so much to learn. And we are gradually having participation of various faculty also and several nephrologists post DM. And this event has grown leaps and bounds. We have had 3 sessions so far. And I would also like to share the feedback that in the recently concluded World Congress of Nephrology, many students came up to us and actually thanked us that it was quite beneficial. They also gave us a few feedback, and we look forward to that, and we plan to evolve. So, yeah. So, based on the request of most of you students, we have also uploaded the presentations on the ISN's YouTube channel. You can access it anytime. And our last 3 presentations have been uploaded. And but trust me, attending it live is always better because you all can participate in the discussion, show, raise your queries, and the grasp is better. So one request to all, I would request all the students to please register for the event in advance. This is because once we get your email IDs, we plan to send you the various questions discussed in that class, important articles on that, other study material, and the various video link once the presentation is uploaded. And of course, for the future events, we have your email. We can send you the link directly. And as I said, we would be trying to upload our recordings of the case presentations and in the ISN's YouTube channel. And we will try and make a list of important questions which can be asked pertaining to the topic, exam point of view, and we'll upload. Most important, this is the academic exercise. We do want volunteers. So all students are requested to please volunteer. You have already come forward and we will be giving an opportunity in the future sessions. So our today's session is on a very important topic in nephrology, acute kidney injury. And the case would be presented by Dr. Harsh Patel and moderated by Professor Sakhuja sir. So on behalf of, again, ISN, it's a proud privilege to have with us Professor Vinay Sakhuja sir, who in one line I can say that he is the teacher of our teachers. So one of the most respected and senior nephrology teachers of our country and the world. And I mean, it's a great honor to be introducing sir. He has many qualifications and academic degrees to his credit. He is presently working as the director in HOD nephrology of Max Mohali and is a professor emeritus of Department of Nephrology, PGI Chandigarh. And all of us, since our birth in the field of nephrology, and before that, we know sir as a previous professor and HOD nephro. He was also the ex-dean and ex-HOD of internal medicine of the prestigious PGI Chandigarh. Sir has numerous awards and distinctions to his credit. Just to name a few, he was the recipient of Colonel Amir Chand Award, Sandipani Rishi Award for Excellence, Distinguished Services Award by the Geriatric Society and various other societies, Amir Chand Award by the NAMS, and various Samman Award by the Z Channel. And Sir has got a huge experience, and as I said, he's a teacher of teachers, more than 35 years experience, and numerous publications and chapters with credit. And more important than that, for all the students, most of your teachers and many of the people of our generation, sir has played a great role in shaping that. I would just take half a minute in just adding one incident. I don't think sir would remember during my MD at FNC Pune, sir once visited the college and he expressed a desire that he would want to discuss the case. And as a MD resident, I happened to present the case. My PG guide was a nephrologist, Dr. Jairam. I presented a case, and incidentally, that case also happened to be AKI. So we had a very fruitful and very encouraging discussion. And after the presentation, sir commented that you presented the case as almost as a nephro resident, and hope to see you as a nephrologist. And trust me, those words were truly a guiding force. And I'm sure many of us and you will have such experiences. So looking forward to the session by sir. And the case will be presented by Dr. Harsh Patel, who is a senior resident in nephrology at MPUH Nadiad. I would just, you all know that how to participate. All of you have been kept muted to avoid any disturbance. So please put your comments and doubts in the chat box. I would also request that whenever sir is asking a question or any question is asked, try to type your answers. It will be good practice for all of you. And at the end, send us your feedback, suggestion, and comments. And we have created a WhatsApp group just to keep you updates and send you education matter on the topics discussed. You can scan this QR code to join the WhatsApp group or contact any one of us if you want any help. So that's all. So without wasting much time, I would request Dr. Harsh to please share his screen and start the presentation.
Good evening, sir. Shall I start?
Yes, yes. Please go ahead. Yes.
So I am presenting a case of Mr. MM. He's 29-year-old male working as IT technician residing in Kheda district. One sec, sir. Presented on 2nd of January 2025 with chief complaints of abdominal pain for 2 days, severe body ache for 1 day, and reduced urine output for 1 day. So I would like to date back his history to 31st of December when he went to trekking for a day, and on the following day in the morning he had abdominal pain which was sudden onset, persistent, diffuse, colicky, not radiating to back or groin. It was not relieved by leaning forward, and it was not associated with fever, nausea, vomiting, jaundice, constipation, or diarrhea. He was treated with injection diclofenac at a local dispensary. Since the afternoon of the same day, he developed severe body ache associated with nausea and 2 episodes of vomiting, which was non-projectile, non-bilious, and no blood in vomit. He had 1 episode of fever, which was 102 degrees Fahrenheit, with chills, and he was taken to nearby hospital, where his blood pressure was 100 millimeter of mercury systolic BP. He was treated with antipyretics and IV fluid total 3 liters given over 5 hours. His reports done suggestive of raised creatinine, urine routine showed RBCs. 2 liters of fluid was given overnight, along with IV diuretics. He passed 20 ml of brownish urine in 5 hours and developed facial puffiness and bilateral pedal edema, which was non-painful and pitting in nature, and it extended up to ankle. He was then shifted to MPUH for further management. In view of anuria, raised creatinine, increased potassium, and metabolic acidosis, right IJV DLC was inserted and he was started on hemodialysis. First dialysis was 3 hours long and it removed 1 liter of ultrafiltrate during dialysis. 1 more dialysis was done on subsequent day. Prior to this, he had no history of insect bite or use of any endogenous medication intake. No complaint of discoloration of skin. No history of joint pain, rashes, oral ulcers. No history of nocturia, bone pains, edema. No history of renal stone disease. So after 5 sessions of hemodialysis in 10 days, his edema resolved, appetite improved, no abdominal pain, nausea or vomiting, but he remained anuric. He was advised to continue hemodialysis till urine output increases and reports become better. His right IJV double lumen catheter was changed to right IJV TCC on 12th of January. He was discharged and advised to stay nearby and to come for hemodialysis thrice per week. He was advised to monitor urine output at home, and before every alternate hemodialysis, his reports were done. He had no improvement in urine output after 3 weeks. And he had no hypotension, headache, or fever during hemodialysis, no edema, no complaint of body ache or nausea, vomiting during or post hemodialysis. His intradialytic weight gain remained around 1 to 1.5 kg. He underwent renal biopsy on 20th of January, which was uneventful. He was advised to continue on hemodialysis And on 25th day since the admission, his urine output increased to 800 ml. His hemodialysis was stopped and advised to follow up daily in OPD and increase oral fluid as per the daily urine output. On 10th day of stopping dialysis, his output increased to 4.5 liters per day. His creatinine came down to 1.5 milligram per deciliter. And urine showed no RBCs. His tunnel cuff catheter was removed on 31st of January. In personal history, he consumes a mixed diet, predominantly vegetarian, has normal appetite, sleep, bowel and bladder habits. He has no history of any addiction. He has no previous history of similar episodes. No history of hypertension, diabetes, seizure disorder, heart disease, jaundice or tuberculosis. In his family, he lives with his parents and one younger brother. He has no one in the family has a history of similar event or any major illness. So to summarize the history, our patient is 29-year-old male. He went for trekking on 31st of December. He developed within 24 hours. He developed abdominal pain for which he received IV diclofenac and then developed nausea, vomiting, oliguria, facial puffiness, and pedal edema. Based on this history, our patient is having dialysis requiring acute kidney injury, probably secondary to hypovolemia and IV NSAID.
Okay.
Yes.
Yes. Okay, just we'll stop you at that point for a short while.
Yes.
You mentioned that he went for trekking on 31st December, but you've not given us any details of that. How long was the trek? How many hours, in other words? What was the distance covered? Was climbing involved, or was it on a level ground? And is he used to such trekking frequently? Does he do that regularly, or was that suddenly a one-time experience? So that part, I think you haven't given us any details.
Yes, sir. He went to Sir Saputara. It is just a small mountain near Kheda only. It was 3 to 4 kilometer trekking. It was uphill trekking. And he's a technician. He hasn't had any experience of similar trekking or any physical activities. Just like that, sir.
Okay. So it took how much time? You said 3 to 4 hours.
It was 4 kilometer uphill and
4
4 kilometer
kilometers.
down. Yes.
Okay, 4 kilometers
Total 8 to 10.
each way. So how much time roughly it took?
He went in the early morning and came back in the evening, sir.
Evening. So it took the whole day.
Yes.
Yeah. Okay. So I asked you this question because you had, in your summary, you said that the AKI was probably due to hypovolemia and the diclofenac.
Yes, sir.
So you didn't connect this trekking with the development of AKI. So do you think that that could also have been a major contributing factor?
Yes, sir. I thought of that.
Okay.
On admission, we also sent the investigations for the same. We thought it might be the exertional related acute kidney injury. He might have developed rhabdomyolysis.
Okay, right. Yeah, so whenever you think of rhabdomyolysis as a possibility in this kind of situation, so the history is very important. So just saying trekking or hiking is not enough. You need to specify how much was the distance, how much was the time involved, was it a uphill, downhill, and is he used to this kind of exertion? So that's an important, because if somebody is used to this kind of exertion, maybe he would have not developed this complication. But if this is unaccustomed exertion for him, then yes, there is a significant possibility that something like this could happen. So, in fact, the main reason why this patient developed AKI could be the rhabdomyolysis itself. Of course, we can't rule out the role of hypovolemia and also the role of the NSAID that he received. So those could also be contributing or aggravating factors in this patient. But rhabdomyolysis is certainly an important possibility to consider in this patient, right? Uh, you did mention that he received 3 liters of fluid over a period of 5 hours.
Yes, sir.
So that's a significant amount of fluid. I mean, generally, you don't give such a large amount of fluid over just a few hours. It could have been over 24 hours or even longer than that. So, over 5 hours, if he received 3 liters of fluid, that does suggest that he was significantly dehydrated and therefore required that much of fluid for hydration. And then he did have a lot of body aches as well. So
Yes.
that could also fit in with rhabdomyolysis because of the skeletal muscle injury causing. Right. Uh, so you said the serum creatinine was elevated. So can you tell us the values and the dates?
Sir, when he went there on 31st of December, his serum creatine was 4.5 milligram per deciliter. His
So that is on the day of trekking itself, after the trekking?
second day, sir.
Second day. Okay, okay. Right. So on the second day, the creatinine was
4.5 milligram per deciliter.
4.5. Okay. Right. So what stage of AKI you think he was in at that time?
He didn't pass, sir, urine at the time. He had oliguria.
Yes.
So
Would you?
his creatine has raised. His creatine is, sir, more than 4 milligram per deciliter. So it is akin stage 3, sir.
Yeah, it is already stage 3. And he was not only oliguric, I think you mentioned that he passed just 20 ml of
20.
urine.
Yes, sir.
So therefore, he is anuric actually.
Yes, sir.
He would fit in with anuria.
Anuria.
Anything less than 100 ml is anuria. So therefore, he's already in stage 3 AKI by the Akin classification, the staging, on the 31st of December, when you mentioned that he had a creatinine that was 4.5, right?
Yes.
So we'll come back to the staging a little later. So just going into rhabdomyolysis a little in more detail. So what are the types of rhabdomyolysis that have been described?
So, sir, types of rhabdomyolysis, that is exertional, the causes, based on causes, etiology, it is exertional, non-exertional. So on exertional, it is, sir, when there is a electric shock, there is exertion like this. And non-exertional, it is drug associated, toxin associated. It might be electrolyte disturbances. It might be genetic causes which may be involved, and endocrine causes.
Mm-hmm. What is traumatic rhabdomyolysis?
After severe trauma, after natural calamities as like earthquake, there will be severe muscle injury. Those who are affected by the earthquake or any road traffic accident also, it might be.
Yeah, so in fact, one of your colleagues have put it in the chat box that it can be classified into traumatic and non-traumatic. So besides the way you classified it, this is another important way of classifying it into traumatic and non-traumatic causes of rhabdomyolysis. In an earthquake, you'll have a crush injury. So that's an example of traumatic rhabdomyolysis. Similarly, in a road traffic accident, you could get traumatic rhabdomyolysis, right? And many of the other causes that you mentioned, like drugs or toxins, etc., genetic causes, electrolyte disturbances, those are all non-traumatic causes of rhabdomyolysis. And while we are going over those causes, might as well complete the list. So conditions like conditions which cause high fever, like heat stroke or malignant hyperthermia or neuroleptic malignant syndrome, can all be associated with rhabdomyolysis. In addition to that, uh, electrical burns, I think you already mentioned.
Yes.
Status epilepticus can be a cause of rhabdomyolysis, right? Of the toxins, alcohol is an important cause.
Yes.
So exposure to a large quantity of alcohol can be a cause. Which are the important drugs which can cause drugs and other toxins?
NSAIDs, then amphetamines, heroin,
Mhm.
cocaine, etc.
Yeah, heroin, cocaine, yes, certainly important besides alcohol. Among the
And
drugs that,
statins.
yeah, very important are statins and fibrates, the
Yes.
drugs that you use for hyperlipidemia management. Those are very important, and there is a large number of psychotropic drugs also, which can uh, give rise to rhabdomyolysis. Any envenomations?
A snake bite, sir. Snake bite can
Which type of snake bite?
myotoxic snakes, sir.
Yeah, so which snakes are myotoxic?
The names I don't recollect.
You're not sure. Well, it's the sea snakes. The sea snakes are classically myotoxic, and similarly, there are some Australian land snakes which have the same kind of effect. So these cause rhabdomyolysis. With viperine bites, which are usually, these are land snakes in India, these generally do not cause rhabdomyolysis. They more commonly cause hemolysis, DIC, or direct nephrotoxicity. So they have a different kind of effect, not rhabdomyolysis, right? So those are some of the important causes of rhabdomyolysis that all of us should be aware of. A prolonged immobilization is yet another condition associated with rhabdomyolysis sometimes, right? So that's an important way in which you can classify these conditions. So, what investigations did you do in this patient to look for evidence of rhabdomyolysis?
We did urine examination,
Yes.
in which it showed specific gravity of 1.02, proteinuria +1, WBCs 5 to 10. Plenty of RBCs were there, and granular cast was seen, sir. We did
Okay.
creatine. When he came here, we did creatine. It was around 8 milligram per deciliter. His CPK levels
Mhm.
were in thousands. LDH was 900. LFTs were elevated. GPT was 56. We did complete blood count. Hemoglobin was 13 grams. We did
Okay.
urine for myoglobin, which came
Yes.
positive. In microscopic examination of the urine, we didn't see any RBCs.
Okay. But earlier you mentioned that urine showed RBCs.
Yes, sir. In dipstick urine examination test,
Okay. The dipstick showed blood, that means.
blood. Yes, sir. Blood. Sorry, sir.
That's an important differentiation. Uh, but the microscopy showed no RBCs.
No, sir.
Okay. So how do you explain that?
So, sir, basically, the heme group that is present in myoglobin and hemoglobin which act with benzidine and orthotoluene,
Yeah.
and it has peroxidase-like activity. So that's why the blood comes positive in dipstick test.
Right, right. Yeah. So that's an important thing for all the students to take note of. When you have rhabdomyolysis and myoglobinuria, you do not get RBCs in the urine, as was the case in this patient, but there'll be myoglobin in the urine, and that will give a positive test like hemoglobin for blood, but microscopy will not show any blood. So that's the important thing to note. Now, uh, when was myoglobin in the urine tested for in relation to the trekking? How many days after that?
It was around third day. It was,
Around third.
yes.
And uh, of course, you did not quantitate it.
No, sir.
Okay, right. So, supposing the patient had come to you 5 days after the trekking, what would have happened to the urine myoglobin?
Urine myoglobin, it might not have been present in the urine,
Why is that so?
because myoglobin has a very short half-life of 1 to 3 hours, and it is almost cleared within 6 hours.
Yeah, that's an important point to remember. So, myoglobin has a short half-life. So, if the patient comes late to you, then obviously the myoglobin from the urine would have disappeared, right?
Yes,
So just having a negative urine myoglobin does not rule out rhabdomyolysis, right?
yes.
And what muscle enzymes would classically suggest rhabdomyolysis?
Creatine phosphokinases, sir.
Yes, creatine phosphokinase. Which other muscle enzymes can you look for?
Other muscle, don't recollect, sir.
Aldolase is
LDH,
another one.
aldolase, yes, sir.
Aldolase and lactate dehydrogenase, yes, LDH, and sometimes SGOT can also be elevated. Not, of course, SGPT, which is specific for the liver. So, yes, classically, you would look for the creatine phosphokinase enzyme. And what degree of elevation would you usually expect? And
Uh,
what is the normal value?
the normal value is within, sir, 230 international unit per 250, 230 to 50 international unit per liter, and to
Okay.
significant elevation is when it is more than 5,000 international unit per liter, and when it has symptomatic presentation.
Yes, yes. So, in most patients with rhabdomyolysis, the CPK will be at least more than 1,000, and in severe cases which present with AKI, generally it will be more than 5,000. And uh, the peak value of CPK is reached how many days after the rhabdomyolysis?
At third day, 36 hours after it remains for 33rd day. At the third day, it will peak.
Peak. Okay, roughly, yes, something like that. Anywhere between 1 and 5 days, you'll have the peak, and then it will decline to normal by how many days?
5 to 7 days, sir. It will.
Yeah, something like another 3-4 days. So, as you said, roughly in about a week's time, yes, it would have come down to normal. So, therefore, that's important, because once again, if the patient comes very late to you, then you may not find any elevation of the muscle enzymes, right? By then, they may have also returned to normal. The urine myoglobin will become negative even earlier, and by about a week or so, a week or maximum of 10 days, even the CPK would have become normal. And so the evidence for rhabdomyolysis would no longer be detectable, right? So these are important timelines to be aware of. I think you mentioned that this patient had dark colored urine also.
Yes, sir.
Yeah, so that is also a feature of pigment nephropathy. So that can occur both with hemoglobin urea and with myoglobin urea, but that is also a transient feature. So once the myoglobin urea disappears, the urine will no longer remain dark in color. What is the circulating myoglobin bound to normally?
Alpha 2 globulin. It binds to alpha 2 globulin. It has weak binding capacity, sir.
Mm-hmm. Yeah, alpha 2 globulin and also haptoglobulin.
Haptoglobulin, yes.
Yeah, both of them. It is bound to them, right? But they also cannot bind large quantities of myoglobin. And while we are on this, what is the molecular weight of myoglobin?
Sir, 17 kilodaltons, sir.
Yeah, around 17 kilodaltons. That would be the molecular weight. Okay. So therefore, in this patient, I would think of acute kidney injury, stage 3, requiring dialysis, yes,
Yes,
and probably, most probably due to a combination of rhabdomyolysis, myoglobin urea, and also hypovolemia. Whether NSAIDs contributed to the problem in this patient or not, um, the possibility still remains, but I have no definite evidence, because we have good evidence of rhabdomyolysis, we have good evidence of volume depletion. This patient required a large amount of intravenous repletion. So those two factors appear to be the most important. NSAIDs may or may not have contributed to the acute kidney injury in this patient.
yes.
Okay. Now, when you are faced with such a patient and you're clinically thinking of myoglobin urea, so what kind of resuscitation would you do in the early phases, supposing the patient has not yet become oliguric? If the patient were to reach you at that time, what would be your immediate management?
I will, sir, attempt large volume resuscitations with normal saline. It might take
Yes.
17 to 20 liters of saline per day. I will give 1 liter per hour first. I will monitor urine output. Then gradually, I will taper the doses of the saline based on the urine output. That is, it should be more than 200 to 300 ml per hour. I will kept in between that range. If patient is severely acidotic, has urine pH of less than 6.5, and serum pH also showing a less than 7.2. Alkaline diuresis hasn't been shown to be effective, too much effective, but if patient is symptomatic, then we can attempt alkaline diuresis. Then mannitol is also shown to be beneficial in earlier stages of rhabdomyolysis. It acts as osmotic diuresis. It increases renal blood flow. Also causes washing out of the cast. So it is theoretically showed to these two also showed to have benefits, but clinically I will first give a large volume resuscitation with normal salines.
Yeah, so I think that should be the mainstay of prevention. So, for instance, if you have individuals who suffer an earthquake and who have not yet been extricated from the crushed building, and they are still under the effects of the crushing, people start intravenous fluids while they are still in that situation to ensure adequate hydration and to prevent AKI in that situation. And as you said, yes, uh, if you can ensure that the urine pH remains a little more than 6.5 and the serum pH not more than 7.5, then this is beneficial. That degree of alkalinization also helps in preventing the development of acute kidney injury. So those are the two most important things in the prevention of AKI. I think mannitol would come much later. That would be less important. That would not be my priority. So intravenous fluid, mainly in the form of normal saline, not pure bicarbonate, and with the watching the urine pH and the serum pH, you may need some amount of sodium bicarbonate to be added to the saline to maintain these pH values and achieve the best outcomes, right? So that would be my priority. Now, one other important aspect which in your history and investigations you have not yet told us, you've given us the muscle enzymes. What other biochemical parameters uh, did you look for in this patient?
Sir, blood urea nitrogen we did.
Yes.
Then electrolytes we did.
Yes. Okay. Can you tell us the electrolytes? Yes.
I haven't mentioned in the slide, sir, but
Yes. Yes.
sodium was, sir, 138 milliequivalent per deciliter. Potassium was 6.7 when he came to MPUH. Chlorides was, sir, 118, and bicarbonate was, sir, 14.1.
So sodium was 138.
Yes, sir.
That was normal. Okay. Chloride was 118.
Yes, sir.
And potassium 6.7.
Yes, sir.
And bicarbonate
14.1, sir.
14.1. Okay. Any other biochemical investigations you did?
Then, sir,
Anything else? You may not have done it, but which would be very important in a patient like this.
calcium and phosphate, sir. Calcium
Yeah.
and
Why?
phosphate levels we
So
did.
why are calcium and phosphate important?
Because in rhabdomyolysis leading to muscle injury, there will be initial hypocalcemia because of sequestration of calcium in the injured muscles, and and there will be hyperphosphatemia because of release of phosphorus from the muscles, sir.
Yeah. So these are very important. So so you didn't check for these
We
at
did
that
check.
time.
We did check, sir. We
You
also
did check.
checked
Okay.
uric acid levels, sir.
Yes, yes. That would be another important one to look for. Yes. So these are the most important ones to look for actually. The potassium levels, which you already mentioned, there was hyperkalemia. The calcium levels, as you said, there is usually hypocalcemia. The phosphorus levels will be high, and the uric acid levels will also be high, right?
Yes, sir.
And these three things which are elevated, the potassium, the phosphorus, and the uric acid, are all because of release of these substances from the injured muscle.
Yes.
Isn't that so? And that is why looking for at these values is very important. right?
Yes.
The bicarbonate obviously is low because of the metabolic acidosis. Do you have any explanation for the very high chloride values in this patient? Was this after giving normal
Yes.
saline?
Yes, sir. When he presented here, it was 118. So he was given 5 liters of total saline before coming here. So
Yeah, so then that explains it, because normal saline has very high concentrations of chloride. It has 154 milliequivalents of chloride. So that explains the high chloride. But despite that, he didn't have any hypernatremia. The
no, sir.
sodium was in
130.
the normal range, 138, right? So these are the very important other biochemical abnormalities that you should look for in every patient with the rhabdomyolysis. And the creatinine levels also.
Yes.
The creatinine levels can rise because of AKI, but the creatinine levels may be out of proportion to
Yes.
the degree of AKI, again because of release from the damaged muscle because of rhabdomyolysis itself, right?
Yes, sir.
So while we are discussing these, can you tell us about any other condition which can also cause AKI, in which you again get all these biochemical abnormalities that we have just talked about?
Yes, sir. We can see this kind of abnormality in tumor lysis syndrome also.
Yes, very good. That's good. So in tumor lysis syndrome, the only difference between that and rhabdomyolysis, there you have lysis of the cancer cells,
Yes.
whereas here you have lysis of the skeletal muscle. But the substances being released into the circulation are the same. So you have the potassium, the phosphorus, and the uric acid. So those alterations are virtually the same, right? So
Yes.
it's very similar biochemically.
Yes, sir.
Yeah. So that is important to remember. Okay. Uh, so that is with regard to rhabdomyolysis and AKI. Now, a few more points about the course of this patient. Uh, the patient continued to be anuric for about 20 days
Yes, sir. 25.
and 25 days.
Yes, sir. He achieved 800 ml on the 25th day of the after.
25th day.
Yes, sir.
Okay, right. So, how did you decide the timing of your kidney biopsy in this patient?
So, sir, by the biochemical investigation, we thought it was a rhabdomyolysis. Generally,
Right.
acute kidney injury improves within 12 to 15 days. Around second weeks, there is usually urine output present. But in after even after 3 weeks, there was no improvement in the urine output, and otherwise patient was stable. He had anuria, so we decided to do urinal biopsy to confirm the cause of the ATN and to also rule out is there any cortical necrosis is there or not.
Okay, fine. I agree with you. I would have done the same. So, in what are there any situations in which you would do a biopsy much earlier?
Uh, if we are suspecting the cause other than the ATN, we can do early biopsy involving the glomerular region, uh, rapidly progressive glomerulonephritis if it is there.
Okay. Any
Uh,
other condition?
if there is acute interstitial nephritis.
Yes, that's an important indication, because in that situation you would like to start
Steroids.
therapy
Yes, sir.
for the interstitial nephritis as early as possible, and that's why you want an early biopsy. So any RPGN and acute interstitial nephritis, or any situation where you have AKI which is unexplained, where you have no obvious precipitating factor for the AKI, yes, you should do an early biopsy, right? So you do an early biopsy. You in fact, that should be done very quickly in that situation, because you don't want to delay therapy of the patient and end up with the CKD. And that is why an early biopsy should be done in that situation. So those are situations where you will do an early biopsy. Whereas when you clinically suspect acute tubular necrosis, acute tubular injury, as you did in this patient, yes, you can wait for about 3 weeks. If after 3 weeks the patient does not go into a diuretic phase, then in fact you should uh, do a kidney biopsy to sort out the problem. And that is what you did here. And okay, so since we have touched on biopsy, can you just tell us the biopsy findings also in this patient?
Yes, sir. In the biopsy, we can see that flattening of the tubules, tubular cells, dilatation of the tubules is seen. There is a moderate interstitial edema. There is cell debris cast is also seen, sir. There is moderate interstitial infiltration is also seen, sir. Edema and infiltration.
So what was the pathologist diagnosis on the biopsy?
Sir, acute tubular necrosis was the diagnosis.
Was the diagnosis?
Impression. Yes, sir.
Yeah, I specifically asked you that because you said that there was moderate degree of interstitial infiltration.
Yes,
So
sir.
that is the important point that you should remember, that in acute tubular necrosis, there is interstitial edema, definitely. So the tubules can be widely separated from each other. But a significant degree of interstitial inflammation is not present. If there is significant interstitial inflammation or eosinophils in that infiltrate also, in addition to lymphocytes, then you have to think of acute tubulointerstitial nephritis, which is a different entity. The presence of casts, of course, can be there in acute tubular necrosis as well. So that doesn't change the diagnosis. What is pigment nephropathy?
So pigment nephropathy is when myoglobin comes to tubules in acidic pH. It binds to Tom Hopstel protein, and it will cause cast nephropathy.
Okay, so what kinds of pigment can cause this cast nephropathy?
Myoglobin and hemoglobin, sir.
Myoglobin and hemoglobin. Okay, so if you wanted to look for myoglobin in this patient, how would you look for that?
I would do, sir, ammonium sulfate test in the urine. I will take 5 ml of urine and add 2.8 gram of ammonium sulfate and mix it gradually to 80% of saturation. Then at 2000 RPM, centrifuge for 10 minutes. If supernatant is turbid, it is myoglobinuria, because hemoglobin as a large molecule will precipitate in the ammonium sulfate source.
No, I'm talking of the biopsy. In the kidney biopsy.
Pigment cast will be, sir, I don't recollect, sir.
Yeah. So on the light microscopy with the usual stains, both hemoglobin and myoglobin will appear similar. So you can't distinguish between them. So you need immunohistochemistry, which your pathologist can do, which can differentiate between myoglobin and hemoglobin, right? So you need IHC for confirming that this is a myoglobin cast nephropathy. So besides, one of your colleagues has put something in the chat box about, since I asked you about pigment nephropathy, and you mentioned hemoglobin and myoglobin, is there a third type of pigment cast that you can find? Not so common? Have you heard of bile cast nephropathy?
Yes, sir. Bile cast nephropathy. In case of obstructive jaundice or liver cirrhosis, there is a severe hyperbilirubinemia, and it will precipitate as bile cast nephropathy.
Yeah. So the third one is bile cast nephropathy. And you're right, yes, whenever there is severe jaundice, when the bilirubin is in the range of 15 to 20 or more than that, then you can get a bile cast nephropathy. And there is a specific stain on the biopsy also, which can identify these bile casts. That's called a Hall stain. So the pathologist can confirm the diagnosis. You know what was the name given to bile cast nephropathy earlier when it was first described?
Forgot, sir.
It was called cholemic nephrosis.
Yes, sir.
Cholemic nephrosis.
Yes.
Yeah. Okay. So, and since we are talking of casts in the kidney, what other cast nephropathy do you know of?
Other cast, myeloma cast nephropathy.
Myeloma cast nephropathy. Okay. We won't go into the details of that as yet. Okay. Was there anything significant in the physical examination of this patient?
Actually, I examined the patient later on when I came to know that I have to. It was, yes, sir. So,
but
no,
were
sir.
there any significant positive
No
findings?
skin discoloration or no arthralgia, no fever or rashes of any kind was seen in physical examination.
The blood pressure was normal.
Normal blood pressure, sir.
Normal blood pressure. Okay,
Yes.
so there's nothing to discuss over there, right? So you already talked about the Akin classification in relation to this patient. So before the Akin classification, what was the classification of AKI that was in use before this?
Rifle classification was there.
Rifle
Risk, injury,
classification.
failure.
Okay.
Risk, injury, failure, loss of function, and end stage, sir. In which a GFR was also included as the criteria.
Yes. In addition to?
In addition to a rise in creatine from the baseline.
And the third criterion
and
was?
Urine output, sir.
Urine output, yeah.
Yes, sir.
Okay. And what was the difference between the loss and end stage?
So when the patient is RRT dependent for 4 weeks, it was loss, and when it was more than 3 months, it is end stage, sir. It was classified as.
Yeah. So loss is for at least 4 weeks, and if it is more than 3 months, then it is of course end stage. So then it is E of rifle. Okay.
Yes.
So this was the staging that was suggested in 2004, and then it was replaced by the Akin staging, which came in 2007, and
Yes.
which was then adopted by the ISN KDIGO as well. So in the Akin staging, what are the criteria for the 3 stages?
Sir, in stage 1, there is a rise in creatinine of 0.3 milligram per deciliter within 48 hours, or more than equal to 1.5 times from the baseline within 7 days, or urine output less than 0.5 ml per kg per hour in 6 to 12 hours. That is stage 1. In stage 2, there is rise in creatinine 2 to 2.9 times from the baseline, and urine output is less than 0.5 ml per kg per hour for 12 to 24 hours. In stage
Okay.
3, there is a rise in creatinine more than 3 times from the baseline. Serum creatinine of 4 milligram per deciliter, or patient is on RRT, and urine output is less than 0.3 ml per kg per hour, or anuria for 12 hours.
Yeah. So in stage 1, in how much time should the creatinine show a rise?
Sir, I don't get you, sir. I don't recall.
So you don't recollect. What is the difference between AKI and RPRF?
In AKI, the rise in creatinine is within days, and in within hours to days, and in RPRF, the rise in creatinine is the loss of function is between days to weeks. It takes days to weeks.
Yeah. So in stage 1, the rise in serum creatinine of at least 0.3 milligram per deciliter should be within 48 hours,
Yes, sir.
right?
Yes, sir.
And the rise between 1.5 to 1.9 fold should be within 7 days.
7 days.
So it is, as you said, hours to days. That's the important thing. It has to be very quick, the rise. Okay. And one other important point to remember here is that you classify patients according to the severest criteria that they fulfill.
Yes, sir.
So if the creatinine is just if the creatinine has gone up just from 1 to 1.5, but the patient is anuric, it is already stage 3, right? So classify according to the severest criteria. And what is the requirement to, if you really want to stage a patient, so what is important for you to know?
For patient should be well hydrated before the classifying.
Yeah, that is fine. Before you do the staging, the fluid repletion should be done.
Yes, sir.
Right? Yeah, but what about the baseline creatinine?
Baseline creatinine, if available, it is.
Yeah, if you don't have the baseline creatinine, then how would you stage the patient? Yeah, you have a problem, isn't it?
Yes.
So whenever you don't have the baseline creatinine, all you have is the creatinine at the time of admission when you first send a blood sample, right?
Yes.
So there can be a problem if you don't have a baseline creatinine, right? So if you have a baseline value, as you often have in patients who've been admitted for some time and then develop AKI, then that is a different situation, right?
Yes.
Okay. So what are the ways in which you can classify AKI? I'm not talking of staging now, I'm talking of classification.
We can classify AKI based on the compartment involved. That is pre-renal AKI, intrarenal renal AKI, and post-renal AKI.
Okay, that is one very old classical way of classifying, but still has, in my opinion, it still has some value in understanding the sequence of events. Okay, any other way?
Then, sir, we can classify into hospital-acquired or community-acquired AKIs.
Yes, that's a very important classification that is relevant even nowadays. So your patient was an example of
a community-acquired, sir.
Community-acquired AKI, right? Okay.
Yes.
So that's a very important way of classifying. How does community-acquired differ from hospital-acquired AKI?
Sir, in community acquired AKI, there is usually pre-renal AKI that might be because of dehydration, hypovolemia, or anything else. And in hospital acquired, it is under observation, and patient develops AKI secondary to the management or drugs given to the patient.
Anything else?
I don't recollect. Sir.
No, not clear on that. Well, community, see, in India and in the tropics, is community acquired AKI more common or hospital acquired AKI?
Community acquired is more common.
Yeah, community acquired by and large has been more common, although the trend is now changing. We are also gradually becoming similar to the Western world, but by and large, community acquired is more common. In community acquired AKI, generally the patients are younger, number one. And in India also, if you look at the community acquired AKI, patients are much younger, generally in their 40s. The average age would be around in the 40s. There generally is a single cause that is responsible for the AKI.
Yes.
Like it may be hypovolemia, it may be acute gastroenteritis, or it may be a snake bite,
Insect bite, yes.
or a tropical infection, right? Whereas in hospital acquired AKI is often multifactorial.
Yes.
Right. So there is in hospital acquired AKI, there is often sepsis, there is often a contribution from various kinds of drugs which the patient is receiving in hospital and so on. So it is usually multifactorial, and patients belong to the older age group most of the time.
Yes.
Right.
And having comorbidities.
Comorbidities, yeah, very common. So there are a lot of differences between community acquired and hospital acquired AKI. And patients with community acquired AKI in India, do they reach early or do they reach late to a
They reach,
tertiary care center?
they reach late, sir, at the tertiary.
Yeah, they generally
That's
reach
why.
very late. So the diagnosis is made most of the time when they are already in stage 3 AKI,
Yes, sir.
right? Whereas hospital acquired AKIs can be diagnosed earlier because they are already in the hospital and they are being monitored regularly, right? So these are the important differences between community acquired and hospital acquired AKI. Uh, have you read up? There is a publication of the Indian Society of Nephrology AKI registry,
No, sir.
which came in the Lancet last year, in the Lancet Regional Health. So an analysis of the AKI registry from India. So have you read that or have other students read that analysis of a large series of patients with community acquired AKI in that? No, you haven't seen it?
Sir, I haven't got the chance, sir. I will read it, sir.
Okay. So you should, all of you should read it because this is a fairly large experience. It's an experience of more than 3,700 patients from several tertiary care centers across India, right? So an analysis of the entire experience. So I won't go into the details of that, but you can read it, and that's very revealing. That's something that all of you should go through. Okay, so you've talked about two classifications, the pre-renal, renal, post-renal, community acquired, hospital acquired. Any other way of classifying these patients?
Then, sir, based on it is AKI is either functional or structural, either medical, surgical, or obstetric, based on the
Okay, depending on the underlying causes, yes, you can call it medical, surgical, obstetrical. Uh, and then you said functional and structural. Yes, that's also right. What about on the basis of the urine output?
Uh, on the basis of the urine output, oliguria, anuria, and at the later stage, it is diuretic stage of the AKI.
No, no. Later stage is a different matter. Oliguric
Oliguric and
versus
non-oliguric AKI.
non-oliguric. Yes.
Yes, sir.
Anuric is just a subgroup of the oliguric AKI. All right.
Yes,
Like your patient had oliguric or anuric, more specifically anuric AKI, right?
yes,
But they can also be non-oliguric AKI.
yes.
So that's another way of classifying these patients. And those who have non-oliguric AKI, they generally have less severe kidney injury, a lower mortality rate, a lesser need for dialysis, and they recover more rapidly. If you have anuric AKI, what are the underlying conditions that you would think of?
If anuric AKI is there, I would consider first causes of rapidly progressing renal failure, RPGN, acute
Okay,
interstitial nephritis, the snake bite, acute cortical necrosis. If
okay. Anything else?
then, sir, any prerenal AKI which hasn't been treated earlier, it will progress to acute tubular necrosis.
Okay. Anything else?
Then, sir, vascular causes can be there in
Like,
renal artery thrombosis,
so it would have to be bilateral to
bilateral
cause.
renal artery thrombosis will
Okay.
happen
Anything
first.
else?
Then, sir,
Anything?
TMAs,
TMA, okay. But anything that is more common than this, which will give anuria, which will cause anuria.
post renal causes.
Yeah, so obstructive nephropathies.
Yes, sir.
So, in fact, that is the first one you should
Yes,
mention when you talk about
first.
anuric AKI. That is the first one you should think of, urinary tract obstruction, right? So, that's important. Okay. And now coming back to the functional and structural. So, what conditions cause functional AKI?
Conditions like hepatorenal syndrome and cardiorenal syndrome, in which renal function is okay, but because of liver dysfunction and vascular abnormality, there will be acute kidney injury.
Okay. Uh, any other causes of functional AKI? Any drugs?
Drugs causing aminoglycosides,
No, not aminoglycosides.
destruction.
They cause structural damage.
Yes.
What about RAS inhibitors
Yes, sir. RAS inhibitor and these
and prostaglandin inhibitors,
inhibitors, they will
right?
cause efferent and efferent arterial involvements.
Yeah, yeah. So those can also cause a functional form of AKI. Okay. Coming to structural causes. So what are the structural lesions in the kidney that are associated with AKI? We have already talked about some of them, but can
Yes.
you just complete
Sir,
the list?
glomerular, vascular, and tubular lesions, then interstitial lesions.
Okay,
Vascular lesions, we have talked about renal artery thrombosis, microvascular TMAs, in glomerular rapidly progressive renal glomerulonephritis, in tubular
right,
acute tubular necrosis and acute interstitial nephritis, tubular
right.
interstitial nephritis.
Yes. Any other less common causes? Most of the common ones you have enumerated, but there are a few less common ones.
Causing cortical necrosis,
Yeah, cortical necrosis is fine. Anything else?
structural.
Uh, You referred to the cast nephropathies
Cast
earlier, so you should mention those also here. Can tumor infiltration cause AKI?
Yes, sir. Humoral.
What kind of tumor infiltrations are you aware of?
Sir, I don't recollect, sir.
No? Well, this can happen in acute leukemias and lymphomas. You can get infiltration by the malignant cells in the kidneys also. And you get enlarged kidneys because of that. And similarly, you can get plasma cell infiltration in patients with myeloma. Right? So this is an example of tumor infiltration. And have you heard of crystal nephropathies?
Yes, sir. Auxiliaria. In
Yes.
auxiliaria, there will be
And
crystal depositions and acute tubular.
any besides auxiliaria, any other
Drug
conditions?
induced. Yes, sir.
Yes.
Certain drugs also causes crystal deposition.
Which drugs are important?
Indinavir, sir, Adzanavir, Indinavir, Acyclovir can
Yes.
also cause, sir.
Yes, acyclovir. Yes, you're right. Any others?
Topiramate,
Methotrexate.
methotrexate,
Methotrexate.
topiramate. Yes, sir.
Yeah, Foscarnet is a rare one. Sometimes sulfonamides also have been associated. Even phosphate, when used as a laxative.
Yes, sir, it can.
And when do you get oxaluria? You mentioned oxaluria. With which can you get oxaluria with some drugs or toxins?
Yes, sir. Ethylene glycol toxicity can precipitate oxalate.
Yes, ethylene glycol. Any other?
Then, sir, I don't recollect.
Oxalate is also the metabolic product if you give large
Large
quantities of vitamin C.
Yes, sir.
Vitamin C. All right. So these are all examples of crystal nephropathies. Okay, there can be others also. I've just given you some of the important ones. Right. Okay. Um, when you consider in general the risk of AKI in a given patient, are there some risk factors which make certain patients more likely to develop AKI?
Yes, sir. There are certain risk factors such as age. Older age patients are more prone to get AKI than male patients. Patients with
Yes,
comorbidities such as diabetes, liver disease, heart dysfunction is there. Comorbidities such as diabetes, hypertension is there. And these patients
yes,
are at more risk to get acute kidney injury.
yes. So you said older age group, diabetics, cardiovascular disease, chronic liver disease
Yes.
are also at high risk. Those with CKD are also at risk of developing
Yes.
superimposed AKI. Then those with malignancies,
Malignancies. Yes, sir.
because of they get exposed to a large number of drugs which can be nephrotoxic, right? Then those undergoing cardiac or complex surgical procedures,
Yes, sir.
and finally those with sepsis,
Yes, sir. Sepsis.
right? These are individuals who are at high risk for development of AKI. Okay. Now, when a patient presents with suspected AKI to an emergency, sometimes you have difficulty in differentiating AKI from CKD.
Yes, sir.
So, how would you differentiate the two?
So first, sir, I will take the detailed history and physical examination. In history, if there is any previous known comorbidities which can precipitate, can progress to CKD. On physical examination, there is if there is anemia, any sign and symptoms of metabolic bone disease there or not, bone pains, etc., nocturia, etc.
Yes,
If there is a nail signs such as half and half nail for
yes,
CKD is
yes.
there or
That's an
not.
important sign if it is present. Yes.
Yes, sir.
Anything else?
Uremic breathing, itching is there or not, sleep
Yes, yes.
disturbances,
Mm.
etc., based on sign and symptoms. Then on radiological evaluation, we can see the kidneys if they are small sized echogenic kidney.
Okay, right. That's important. Yes. What about anemia?
Yes, sir. Anemia. If anemia is, we can see physically based on physical signs and also a normocytic non-chromic anemia in blood reports. We can, sir.
Yes, yes. And finally, if you find left ventricular hypertrophy,
Hypertrophy.
that can also be a feature of CKD. So those are the indicators that you're dealing with CKD rather than AKI in a patient. Okay, in a patient with acute tubular injury, what will the urine sediment show you?
In earlier phase, there will be hyaline cast, and if it has progressed to ATN, there will be a granular cast will be there, sir. Uh,
Granular cast. Okay, so there can be granular cast. Anything else?
uh, uh, Mild proteinuria can be there, space and
Uh, on on microscopy, anything else?
cast. I don't think so.
The other important thing that you can see on microscopy is tubular epithelial cells. So
Tubular
if you see a lot of tubular epithelial cells, in addition to granular casts, always think of acute tubular necrosis. Uh, how do you distinguish pre-renal azotemia from acute tubular necrosis?
We can see, sir, fractional excretion of sodium, which is less than 1% in pre-renal and more than 3% in ATN. There will be BUN by creatinine ratio, which is more than 20 in pre-renal and less than 20 in ATN group. Specific gravity will be more in pre-renal. That is one. It might be around 1.02, and in ATN it will be 1.01.
Yes, yes.
Osmolarity will be also higher side on the pre-renal. It will be more than 350 and it will be less than 350 in ATN.
Hmm. Yeah, so those are some of the important urinary indices that you've mentioned. You can go through the full list. The other important differentiating feature is, as I already discussed, is the urinary sediment,
Sediments.
right?
Yes.
In pre-renal azotemia, the urinary sediment is usually normal. That is one. And pre-renal azotemia rapidly responds to fluid administration, whereas ATN will most probably not respond to just fluid repletion. If acute tubular injury has already occurred, fluid repletion will not reverse the process, right? So after that, coming to an important area which hasn't yet become clinically useful is that of biomarkers.
Yes, sir.
So what biomarkers have been used to help in the diagnosis of AKI? Can you name some of the important biomarkers?
Yes, sir. So, tissue inhibitor of metalloproteinase 2, that is TIM2, and insulin growth factor binding protein 7, IGF-BP7. These two are used to detect AKI earliest possible. That is within 12 hours we can diagnose AKI. We can suspect or diagnose AKI with the help of these two markers. Then there is glomerular injury markers such as BUN, creatinine, and cystatin C. Cystatin C is 13 kilodalton molecule which is freely filtered and reabsorbed through proximal tubules. So it is also important markers for early detection and for prognostication of kidney injury. Then kidney injury molecule 1 and neutrophil gelatin associated lipocalin. These two are also markers of tubular injury. There are other markers like IL-18, which is also which is produced by macrophage monocyte and also tubular cells. Then to differentiate between ATN and AIN, there is interleukin 9 and TNF alpha, which have also been considered. to differentiate?
Yes. So you've given us some of the important ones. Of course, there is a long list of biomarkers that have been described, uh, but none of them have yet reached clinical relevance. One, these tests are very costly. Two, most labs don't perform these tests. And they have not yet reached the stage where you can apply them clinically. So they can only be prospectively studied in situations where there is going to be a high probability of AKI developing, and you are aware in advance of that, so you can monitor these biomarkers. And yeah, uh, the first marker that you mentioned, that is TIMP2. So that is TIMP2 and the IGF-BP7. It is the product of these two markers that is used. If the product is greater than 0.3, that is suggestive of AKI, and these are measured in the
Urine.
urine. Yes. So these are not in the blood, these are measured in the urine. Have you heard of any new marker that has been described for acute interstitial nephritis?
I have heard, sir, TNF alpha and IL-9 for to differentiate between ATN and AIN.
You can read up in 2023, a marker called CXCL9 has been described. This is a interferon gamma induced chemokine which is involved in lymphocyte chemotaxis, in attracting the lymphocytes to the kidney. And they have shown that the urinary levels of this marker are more than 7 times higher in patients with biopsy proven interstitial nephritis. And the expression of this marker in the kidney tissue in these patients has also been shown to be about 4 times higher than the control group. So this is the latest biomarker that has been described. This report came only in 2023, right? So you can read up about this. Are you aware of the term renal angina?
I have heard, sir, but I don't recollect, sir.
So that's another thing that you should read up. So just as you have cardiac angina, which is a precursor of the acute coronary syndrome, so renal angina is a state in which you can anticipate the development of AKI. Those patients are at high risk for development of AKI, right? So there is a scoring system called the Renal Angina Index, and the score can range from 1 to 40, and it is calculated on the basis of, there is a condition score and there is a creatinine score, right? And if you have a renal angina index of more than 8, that suggests a strong possibility of AKI, all right? So you can read up this renal angina index. Now, since the biomarkers have not yet proven clinically useful, is there a simple clinical test that you can do?
Yes, sir. We can do, sir, furosemide stress test.
Yeah, that is the test that was in my mind also. So how do you do this?
Sir, in diuretic naive patient, we give 1 milligram per kg IV furosemide, and we wait for 2 hours. If urine output is less than 200 ml, then it is 87% sensitive and 84% specific to that patient might develop dialysis dependency.
Yeah, so you give a dose of up to 1.5 milligrams per
Yes.
kilogram intravenously and watch the urine output. And if you get a urine output of less than 200 ml in 2 hours, then it suggests that this is AKI stage 3, and the patient is likely to require dialysis. Whereas if you have a better output, an output more than that, then probably the patient will not require dialysis and will recover quickly, right? So this is the furosemide stress test. So some people feel that this is better than even the biomarkers, right? Um, what are the phases into which you can divide the course of acute tubular necrosis?
Phases, sir. Sir, I don't get.
You already talked about a oliguric phase, didn't you?
Yes, sir. Oliguric, anuric, and diuretic phase, sir.
Yeah, so you have the initiation phase, which is the first 24 to 48 hours. Then you have the oliguric phase, which can last up to about 3 weeks. Then you have a diuretic phase, which may last a few days only. And then you have a recovery phase,
Recovery phase. Initiation.
right? So those are roughly the 4 phases through which the patient passes. So what is the mechanism for the development of oliguria in these patients? Why do they get oliguric?
Sir, patient in a pre-renal AKI, there will be hypovolemia. There will be reduced perfusion in the kidney.
Yes, so there is a reduction in the renal blood flow, and as a result of that, there is a decline in the GFR.
GFR.
So that is one of the reasons why you get oliguria. Anything else?
Then, sir,
You described some findings in the biopsy which can also explain the oliguria.
shading of tubular epithelial cells.
Epithelial cells, and those epithelial cells can then block the tubular lumen along with the casts. Obstruction. So tubular obstruction can also contribute to oliguria. Anything else?
Then, sir, in such cases such as rhabdomyolysis, there will be a direct toxicity of myoglobin, and there will be also reactive oxygen species formation, which will also cause add to the acute tubular injury.
Yes, that is true. But in addition, at the kidney level, what you get is tuberorexis. In other words, rupture of the tubule basement membrane. And as a result of that, there is also back leak of the filtrate into the interstitium, right? So these are all the factors that contribute to the oliguria. Next, coming to, we don't have too much time left. It's already 9:30. So I'll just take a few minutes more. So in a patient with the oliguric AKI, how do you decide when to go ahead with dialysis? That's a very important area.
Yes, sir. I will assess, sir, physical condition, volume overload is there or not from the baseline. If there is more than 10% increase in the body weight, if there is hyperkalemia, if there is a severe metabolic acidosis is there, there is severe, if there is a severe renal dysfunction is there, patient is symptomatic, then I will plan to initiate patient on the hemodialysis, sir.
So what is the data available on early versus late versus very late dialysis?
Certain trials have been done, sir. The first among those trials was landmark trials was Elaine trial, in which they did the very early versus early, that is 6 and 12, 8 and 12 hours early versus very early versus early, and In those patients, they found that very early had mortality of 38% and early had 54% of mortality, but they were mainly surgical patients and number needed to treat were very less. So it was not significant. Then there comes
Can you just summarize? So would you go for early dialysis or late dialysis in a patient with AKI?
So, sir, based on these trials, there was no significant difference in early versus late dialysis. So, I will individualize each patient, and based on the condition, I will decide whether to initiate or whether to wait further.
Yeah, so early dialysis does not reduce mortality or improve outcomes. There are at least 3 or 4 trials which have been done. There is the Acute study,
Yes.
the Ideal ICU trial, and the START AKI study, right?
Yes.
All of which have shown that early initiation of dialysis does not improve outcomes, and therefore early dialysis is not recommended, right?
Yes.
So you generally would consider dialysis only in stage 3 AKI or even later than that,
Yes.
right? But obviously you should not put the patient at risk for developing a life-threatening complication like hyperkalemia or pulmonary edema, right? So dialyze before that happens. When would you consider intermittent hemodialysis, and when would you consider some other form of dialysis?
So when the patient is required to get the rapid solute clearance and more ultrafiltration within short time, and if he is hemodynamically stable, then I will consider here intermittent hemodialysis, sir.
Yeah, so where you have hemodynamically stable patients, intermittent hemodialysis, and how often will you do this?
We'll do, sir, thrice a week with achieving KT by V more than equal to 1.2 in each hemodialysis.
Yeah, 1.3, so that you have 3.9 per week.
Per week.
So that would be the recommended. And for a hemodynamically unstable patient, what would you do?
There are two modalities, sir. Sustained low efficiency daily dialysis, and then there is CRRT,
Yes.
continuous renal replacement therapy.
Hmm.
So the trials done to compare these modalities did not show any significant benefit of CRRT over SLADE. There are Ronco et al., ATN and renal trials. So based on patient's condition, if there is any intracerebral if there is intracerebral etiology is there, if patient is having any liver disease and a plan for liver transplant as a bridging therapy, I will use CRRT over SLADEs.
Okay. In all the other situations, you will prefer to use SLADE?
I will personally, sir. I haven't have much experience of CRRT, so SLADE, I have seen that many patients have improved over with SLADEs.
Yeah, so there may be disagreement on this point. There may be purists who believe in CRRT, like Dr. Ravi Mehta in the US, who is one of our alumni from PGI. But my experience with SLADE is the same as what you just said, and SLADE has many advantages, particularly for a country like ours. It's much cheaper. The anticoagulant use is much less. The duration of SLADE is much less. The nursing involvement is much less. The cost is much less. Above all, you don't require any replacement fluid, and therefore SLADE has several advantages over CRRT in our setting, with the exception of liver disease, which you already mentioned. Now, so since we don't have too much time left, there's only one other entity that I would like to discuss before I finish. What are the long-term consequences of an episode of AKI?
So, AKI patient, most of the patient, around 80% of the patient will recover to the fullest. Some patient may get acute kidney disease, and some around 9 to 10% patient may develop a CKD over a long period of time.
Okay. What is AKD?
AKD is basically acute kidney injury, which is more than 7 days, and it persists less than 3 months, up to less than 3 months.
Yeah, more than 7 days. That is AKD. Yes. After 3 months, it becomes CKD, obviously. So, yes. So the major risk of patients with AKI in the long term is the development of CKD, which may affect a certain percentage. We don't know the exact number that will get affected and which will go on to CKD, but a certain number will develop CKD in the long term. The mechanisms of this are not yet fully understood, and we also don't have any reliable methods of preventing or delaying the occurrence of CKD in these patients. Some people have suggested using ACE inhibitors or ARBs in such patients, but the recommendation is that at 3 months after a supposed recovery from AKI, the patient should definitely be followed up to assess his renal functional status. So that is the current guideline regarding follow-up of these patients to see whether or not they are going on to develop CKD. So I think it's already almost 9:40, so we can stop here. If any of you have any particular questions, or if Dr. Jasmine or Dr. Vineet have any important thing that they would like to add, they are welcome to do so.
Thank you, sir. It was a very interesting discussion. And I would also like to thank many people who were actively posting in the chat box, like Dr. Edwin Fernando, sir, Dr. Gloomy Corn, Dr. Mega, and many others who have made the discussion very active and engaging. So there are few questions that we would like to take, which were posted in the chat box. One was pseudo AKI by piperacillin tazobactam. Someone has commented that pseudo AKI can be seen with piperacillin tazobactam, like it inhibits the creatinine secretion and so. So when should we consider it, and how should we differentiate from true AKI?
Even I am not very sure about that. Generally, blockade of tubular secretion of creatinine is seen with drugs like cimetidine, or when you're using co-trimoxazole, the trimethoprim component can block the secretion of the tubular secretion of creatinine and produce an elevation in the serum creatinine levels. And generally, when you withdraw the drug, the creatinine levels come down to normal. I haven't experienced this with the piperacillin tazobactam.
Yes, so mainly it is seen with the anti-tumor agents like VEGF inhibitors, etc.
Yes.
Another question was, how can we suspect mitochondrial myopathies as a cause of rhabdomyolysis? Like in what patients we will suspect underlying mitochondrial myopathy?
Yeah, there are certain genetic causes which Dr. Harsh Patel also referred to when we talked about the causes of rhabdomyolysis. So these are very rare conditions where you might sometimes encounter rhabdomyolysis, but I really have no experience of them.
There will be, ma'am, recurrent episodes of such rhabdomyolysis, and There will be family history also if it is at all genetic cause is there.
Okay, fine. Thank you.
Sir, another question that was put was, can we also use plasmapheresis and heme adsorption in early rhabdomyolysis, like they can act by removing?
Yes, I have seen a paper very recently mentioning this, that heme adsorption, particularly if the serum myoglobin levels are very high. They have even mentioned a figure of, I think, 10,000, if I remember correctly. So if you have very high levels of serum myoglobin and the patient has come early to you, then you can use, and what they have used for this purpose is the cytosorb cartridge. So there is this one report which has recently come for use of heme adsorption for treatment of rhabdomyolysis.
Similarly, sir, Dr. Shaurya has asked that can medium cutoff dialyzer also be used in the early stages of rhabdomyolysis? Like we are in PGI using this MCO dialyzer for myeloma cast nephropathy patients, but can this be employed in rhabdomyolysis? I'm not sure actually.
Yeah, even I have no idea about this, but certainly worth a try if the patient comes well in time.
Sir, another question was, does lactate rise in traumatic rhabdomyolysis?
Not that I'm aware of. Not as far as I'm aware.
Okay. Another question is like, what about the role of hemodiafiltration in rhabdomyolysis? Does it offer any added benefit over routine hemodialysis?
Again, I have not seen any reports of hemodiafiltration in this condition. Not seen any reports.
Sure. Sir, very interesting and a practical point Dr. Yashendu has raised, that why does creatinine lag behind the urine output in the recovering phase of ATI? Like we usually see a lag of around 3 to 4 days before the creatinine starts settling, and even the creatinine may rise to some extent once the urine output has started opening up. So why this lag is seen, and how long this lag can be?
Oh, this lag can be for anywhere between, say, 5 and 10 days. Not surprising. It's actually that the fact that even though the urine output has improved, the GFR at that stage has not yet improved, and therefore the creatinine is therefore not being cleared. So it takes a longer time for the GFR to improve, and it's only when the GFR improves that the creatinine starts declining. So that is the main reason.
Dr. Harsh, you can probably take this question, that why did the patient have abdominal pain? Like what could have attributed to the abdominal pain that triggered the use of NSAID in your patient?
Exact reason I don't know, but it might be gastritis also. He had roamed for a day in trekking. The exact reason we don't know, but it improved certainly after some days on its own.
So with this, I think we have covered most of the questions. I like to thank you for this wonderful bedside, and I like to thank Dr. Harsha and Dr. Vineet sir also. So we can conclude if there are no other suggestions. Thank you all.
Thank you very much for the opportunity to take part in this.
Thank you and good night.
Thank you very much.